the title as you read says ventilator-associated pneumonia, which I'll be pronouncing it as VAP. Diagnostic technique and state of the art. And I kept hitting my head very hard as to how should I handle with it. Why Rajesh decided to give me this topic, because he knows that for last more than a decade I'm struggling with it. I've done about 4 research projects in it. I have certain data from my institute, from the ICU. But whether it is going to be state of the art, this is for this able audience to decide. And of course we all know that why VAP is important. Because the incidence is exceedingly high, and if you look at the crude mortality is 71%. So therefore the patients who develop VAP, it's okay. VAP, there's 71% chance that they are likely to die. Now the question was asked whether these people develop VAP because they have to die anyway. So they are too sick, so they develop some complications, so they die. This was the thinking almost say 2 decades back. But soon enough we came to know that the impact of VAP is that it increases the duration of mechanical ventilation, it increases the ICU stay and hospital days, and now we know that it also increases the mortality. And the latest study that we conducted at AIIMS, it was a study of early versus late onset pneumonia. And when we compared the cases with the control in our own ICU, we knew that the survival of the patients who did not develop VAP was significantly better than the one who developed VAP. So coming quickly to the diagnosis. Now diagnosis would be 2. 1, whether the patient has VAP, and number 2, if he has VAP, what is the bug and what is its sensitivity pattern. And we all know that traditionally VAP is divided into early onset and late onset. Early onset is caused by simple organism like methicillin sensitive streptococci. And late onset VAP is caused by these beautiful looking dangerous organisms like Staph and Pseudomonas and Enterobacteriaceae. And of course we know we all working in the ICU are struggling with Acinetobacter these days. Now quickly coming to the clinical diagnosis. Do you diagnose, if I ask a question to young residents, how do you diagnose ventilator-associated pneumonia? The commonest answer is tracheal aspirate, or more fancy answer is bronchoscopy. But the fact of the matter is that when you are in the intensive care unit, the most of the time the diagnosis of VAP is clinical. And way back, Johnson had given a criteria. If the onset is after 48 to 72 hours, if there is a presence of new or progressive pulmonary infiltrates, along with fever, leukocytosis or leukopenia, or purulent secretions, 2 of them is there, you call that patient has developed VAP. Is it true? Is it state of the art? Now if you look at the fever, the sensitivity and specificity of fever for diagnosis of VAP is something like 67 and 66%. That means quite often you would be wrong. If you look at radiographic features, the specificity would vary from 96 to 58 to 33 to 27 depending upon whether you are looking at an alveolar infiltrate or Sillett sign or single air bronchogram, meaning thereby that you can go wrong. If you look at the purulent expectoration, you can go wrong. So therefore, there was a score was devised called clinical pulmonary infection score, CPIS, popularly known, which took into account fever, leukocytosis or leukopenia, secretions, and PF ratio, chest radiography, and also microbiology. And the initial study says, when this study was done only on 28 patients. So initial study said that the specificity was 100%. Now this is statistical jugglery. And after that, when this CPI score was put to test, Then it was realized that sensitivity and specificity was something like 70-80%, or 71 specificity were further low. So therefore, it's a good score. It's a good score, but it's not sacrosanct. It's not sacrosanct. Meaning thereby, you have to hit your head. You have to hit your head. You have to use your clinical medicine. You have to rule out other causes. You have to rule out malignancies. You have to rule out atelectasis. You have to rule out pulmonary edema. You have to rule out pulmonary hemorrhage to diagnose ventilator-associated pneumonia. Then came the fancy thing, the biomarkers. Why can't there be a marker? You do a test and then it should give you an answer. Because when you do endotracheal aspirate, there is a lot of colonization, you get a lot of positive cultures. So there is a lot of soiling of the flora. So there is a colonization and there is infection. You are not bothered about colonization. You don't want to treat colonization. You want to treat infection. So what do? And I said clinical data are non-specific. So what is an ideal marker? Ideal marker, it should be negative in colonization. One, it should be positive in infection or injury. And that will be an ideal marker. So do we have one? It should be measured within hours so that antibiotics can be started. And biomarkers are not based on the positive cultures. And there are certain biomarkers including procalcitonin, C-reactive protein, plasma activating factor and S-TREM. These investigations are on. But till date, no clinical utility. Because if the test has very high sensitivity, it has a very low specificity. So far, please do not use biomarkers for diagnosis of WAP. Finally, is the microbiology gold standard? If I was to diagnose WAP, if I was to say 100% that this patient has WAP, you should demonstrate lung inflammation, you should isolate the organism, which means I should do lung histology and isolate the organism, and then I say, okay, this patient has ventilator-associated pneumonia. Of course, that is not possible. So therefore, you do some invasive tests. You do tracheal aspirate, you do bronchoscopy, you do non-bronchoscopic protected BAR. Even on today in 2011, the tracheal aspirate is the most common sample which is available, which is tested all over the world for microbiological diagnosis of WAP. And there are certain difficulties. The difficulties are, there is sometimes impossible to discriminate between bacterial colonization and pneumonia, and most often the clinical criteria have been used. Finally, the results of microbiology are never available at the time of starting antibiotics. And this was a survey done in 28 ICUs where it was found that bronchoscopy was the least used investigation and qualitative tracheal aspirate was the most common specimen which was used for microbiology. We almost a decade back thought of looking at the bronchoscopy as an investigation of choice for diagnosis of WAP, and what we did that we compared bronchoscopy with the tracheal aspirate with the indigenous non-bronchoscopic valve that we use two catheters, number 8 and 16 French, and with the mucus extractor. Whole thing costs about 25 to 50 rupees. And we compared the non-bronchoscopic valve with bronchoscopic valve, and the results were glaring. We realized the protected valve, bronchoscopic valve, bronchoscopic brush, and an endotracheal aspirate had almost similar positivity, with bronchoscopic brush being the best. And what we did that we compared these data with the international data. These are the international data that's published in the American Journal of Respiratory and Critical Care, and this is the AIMS study which was also in the same journal. The sensitivity and specificity of non-bronchoscopic valve done with the two catheters in this patient is as good as bronchoscopy. So therefore, if you are investigating a patient of WAP, my request and advice to you would be use two catheters, use a mucus extractor, go blind, go and take the sample, and the results will be as good as bronchoscopy. And you might say, why? Because there are autopsy studies, and when the patient develops VAP, the VAP may be in the left lower lobe, but actually the pathology is in both the lungs. So therefore, wherever you go with your catheter, as long as you are going into the distal airways, as long as you are collecting a protected specimen, that is fine. Now there are certain factors which affect the outcome of microbiology. And these are the volume of lavage, sampling technique, and culture threshold. And there comes the role of your microbiologist. The experience of the microbiology, the quantitative cultures are extremely important. And your cutoff values are extremely important. So therefore, that way, I would say we are gifted because we have a full-fledged microbiological department. Another study which we conducted was we wanted to look at how does our ICU gets colonized? How do we discriminate colonization from the infection? The genesis of this study was that when we used to go to the ICU, the resident will show a culture. Culture Pseudomonas positive, tracheal aspirate. I have already started him on something like meropenem or ceftazidime along with ciprofloxacin. I said, why? Sir, the culture is there. I said, does this patient have fever? No. Does this patient have leukocytosis? No. Does the X-ray has changed? No. But sir, culture is there. Patient is not improving. So what we thought was, this was an ambitious project. We want to determine the organism which are colonizing, and we want to look at the dynamics. Our microbiologist glared with us when I told her that we will do 6 cultures every 48 hours. Axilla, perineum, nasal cavity, gastric lavage, and endotracheal aspirate. To be done within 12 hours of admission, and to be done at 48 hours, then 5th day, then 7th day, and weekly. And if the patient developed pneumonia, we did a bronchoscopy. And all patients were examined by semi-quantitative method. Axillary swab, nasal swab, perineal swab, pharyngeal swab or aspirate, IV catheter, and Ryle's tube aspirate, and of course blood culture. And we were horrified. This is within 12 hours, 48 hours, 5 days, and thereafter, you would see that by 7th day, there was close to 100% colonization of various. And that's what worried us. And what we wanted to, this was a prospective study, and we wanted to look at as to what is happening to this flora. Now this is dynamics of Staph aureus nasal colonization. At the beginning, 44% were MRSA. By 7th day, 81% became MRSA. Meaning thereby, as the time passes, your bugs become more and more resistant type. And I have no time to show you everything, but this is how the airway colonization from day 1 to day 7 grew up, and similar was the gastric colonization. What was the aim of this study? To look into whether this colonization culminate into ventilator-associated pneumonia. Now these are the day of colonization. The bluish ones are the airway colonization, the brownish ones are gastric colonization, and black was the one with the patients who have developed pneumonia. Out of 50 patients that we studied prospectively, 5 patients developed pneumonia. Now the biggest question is that if we were to believe these cultures, which were positive on 1st day, 3rd day, 5th day, we would be treating all these patients. The conclusion was that all these colonization are not to be treated. But presently what we are looking at it, whether the serial cultures can help in picking up a correct antibiotic, meaning thereby, suppose this patient developed pneumonia on 23rd day, we already have a report of this culture, which was done maybe 2 days back or maybe 72 hours back. Will it help us in proper selection of antibiotic? This study is going on. We will have the results in say 1 to 1.5 years. One of our brightest residents is conducting this study. So what is the choice of diagnostic strategy? It depends upon the local expertise, physicians and the microbiologists. Also the risk of the patient, experience and the cost. The quantitative culture is a costly thing. It is a very resource intensive. Microbiologists glare at me as to you are making us do 50 cultures for one single patient and for what? And we being a government organization are blessed. We can conduct such studies. So what is the conclusion of my presentation? The conclusion is the clinical diagnosis still is the best way to make early diagnosis and start appropriate empirical antibiotics. The biomarker hold promise but not useful in clinical practice mainly because of lack of specificity. They are sensitive. Procalcitonin is sensitive. But it's not specific because they are increased in variety of injuries. Even there is infarction, it will increase. Because of the basic disease, because of pneumonia, these markers will be high. So you cannot rely on them. Blood cultures also should be done in all the cases. Only if you grow the same bug in blood culture and same bug at tracheal aspirate, you can say that this bacteria is causing. Otherwise, you really cannot believe it. The samples of lower respiratory tract to be obtained, tracheal aspirate, bowel or brushing or non-bronchoscopic bowel. Evidence is level 2. No respiratory secretion testing required in absence of clinical evidence of VAP. The qualitative cultures lead to therapy for more organisms as compared to quantitative cultures. That is level 1. And non-bronchoscopic bowel can be used to obtain reliable samples for quantitative cultures. At the end, I would like to thank my microbiology colleagues, Professor Aarti Kapil and Dr. Seema Sood, and my young residents who have conducted this study. Mr. Chairman, ladies and gentlemen, I thank you very much for your kind attention.